I'll share the.
Yes, doctor. I'll start. I'll start now in 2 minutes.
I'll share the.
Yes, doctor. I'll start. I'll start now in 2 minutes. Good evening, all. I'm thrilled to welcome you all for today's webinar on tubercular lymphadenopathy. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Sohail Ahmed. Dr. Sohail Ahmed is an accomplished respiratory medicine specialist and academician, currently serving as assistant professor at Al Amin Medical College, Vijaypur. A university rank holder in MD Respiratory Medicine from RGUHS. He has also earned top honors, including first prize in 34th Pure View quiz conducted by CREST. He previously served as assistant professor at Kanchur Institute of Medical Science, Mangalore, and is an active contributor to medical education as a CME speaker and postgraduate presenter and moderator. Dr. Sohail work reflects a strong commitment to teaching, research, and advancing respiratory healthcare. Over to you, Doctor.
Thank you, Vijay. Thank you for again warm welcome, and I welcome everybody for this today's webinar, which is based on tuberculosis and how tuberculosis is involving the lymph nodes. So before I proceed or I start the webinar, I want to ask all the participants, am I audible and my voice is clear and understandable, as well as my screen is visible properly? Yes. Okay. Very good. Thank you for your response. So let us begin with today's webinar. So can all of you tell me how frequently you encounter a patient of a TB lymph node or a tuberculosis lymph node in your day-to-day practice, or in your wards, in IPD, OPD? How frequently or how many you have seen? Okay. All right. So let's begin with our webinar once weekly, very often. Okay. So we have a mixed response. Okay. So let us begin. So before I start my webinar, I want to state some myth or fact. And at the end of the webinar, you guys will be able to differentiate which is myth and which is a fact. So let us start with the first one. Granulomatous lymphadenitis on an FNAC confirms tuberculosis. How many of you tell, is it yes or no? If on FNAC report you see a line granulomatous lymphadenitis, that means tuberculosis. How many of you agree with this? Okay, yes. Okay, all right. So we again have a mixed answers. Okay, the next point is mediastinal lymph node TB is classified as a pulmonary TB. How many of you agree? When you are answering, please write 1, 2, 3, 4 so that it should not be a confusing. Okay. Yes, mediastinal TB is classified as pulmonary TB. Yeah, no? Okay, all right. Okay, the third point is an enlarging lymph node during ATT always indicates treatment failure. If a lymph node is enlarging, despite the patient is taking anti-tubercular treatment and patient is compliant with the treatment, but if the lymph node is enlarging, it is called as treatment failure always. No, no. Okay, good. So a patient of lymph node TB, but the aspirate is showing negative CBNAT or gene expert. That means the lymph node TB is ruled out. If the CBNAT or gene expert is negative, it is ruled out. No. Yes. Excisional biopsy may still be necessary despite FNAC suggesting TB. So you have a patient of a TB, you have ordered an FNAC. It is suggestive of tuberculosis, but do you want to go for excision biopsy? So don't worry. If you are confused now, just stay calm and listen to the class. At the end of the class, you will get all the answers for these myth or a fact. Okay. So let us begin with our today's session. So I want to begin with a case. It's a very interesting case. So he is a 28-year-old man, presents with bilateral axillary swelling, which was for a duration of 9 months. And the swelling was more on the left side when compared to that of the right side. And the patient gives history that it's a progressive enlargement, and patient also has a low-grade fever, okay, and also loss of appetite. When we examined the patient was having firm, non-tender, mobile nodes, and the largest node was 4 to 5 centimeter in the left axilla. FNAC was done, and it was showing granulomatous lymphadenitis. So this is just a introduction. So now what you want to do? A, B, C, D. You want to straight away start with the ATT. You want to obtain CBNAT or gene expert, or you want to go for an excisional biopsy, or you want to observe and review. B, C, B, C. Okay. 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 All right. So that we'll see at the end again. So let us begin with our today's webinar. So why we are discussing this today's webinar? Why the tubercular lymphadenopathy or lymphadenitis matters to us? Because as we all know, it is one of the most common form. It is one of the most common form of the extrapulmonary tuberculosis. It's one of the most common form of the extrapulmonary tuberculosis, and the most common lymph nodes involved here are cervical lymph nodes. Other group of lymph nodes are also involved, which includes axillary, mediastinal, inguinal. Okay, so all these are other group of lymph nodes, but the most commonly affected are the neck or cervical lymph nodes. How does these patients presents to us is very slowly enlarging lymph node swelling, or sometimes the swelling is there and patient remains asymptomatic. And several studies or reports have shown that these tubercular lymphadenitis are quite common in females more than males. So we have to keep these differential diagnosis in the mind whenever we see an enlarged lymph node. The first thing is it can mimic lymphoma. It can also mimic a metastatic malignancy. It can mimic sarcoidosis. And the diagnosis often requires a tissue confirmation. Yes, there can be a paradoxical worsening despite appropriate adherence and compliance to the treatment. So all these are important points to be kept in mind when we are dealing with the tubercular lymphadenitis. So the first myth, one of the myth in our first slide, mediastinal lymph node is considered to be as a pulmonary or extrapulmonary. So we have a patient who has enlarged mediastinal nodes, yes, but there is no lung parenchymal involvement, no evidence of any cavity or consolidation in the lung. So how do you classify this TB as? How do you want to classify this TB as? You can just write PTB or EPTB or both. Both extrapulmonary, EPTB. Okay. So mediastinal lymph node TB is without any lung parenchymal involvement is classified as extrapulmonary TB. Okay, so please keep that in mind. If there is a no lung parenchymal lesion, only lymph node is involved. Okay, so that is called as mediastinal lymph node or extrapulmonary TB. But please don't confuse mediastinal lymph node with the parenchymal involvement can be called as pulmonary TB with extrapulmonary TB. Okay, so isolated mediastinal lymph node involvement is considered as an extrapulmonary tuberculosis. So what do you mean by this tubercular lymphadenitis? It is a commonest form of extrapulmonary TB, and it is resulting from an infection of the lymph node by our very own Mycobacterium tuberculosis complex. So as already told you, commonest form of extrapulmonary TB is the tubercular lymph node. We have other extrapulmonary TBs like CNS tuberculosis, skeletal tuberculosis, abdominal tuberculosis, genitourinary tract tuberculosis, miliary tuberculosis. Okay. And usually they present with a chronic onset of lymph node enlargement. Cervical group of lymph nodes are most commonly involved, and sometimes they can be, most of the time they are single, sometimes they can be multiple. And these lymph nodes can be peripheral or deep-seated. Okay, I'll tell you what are the sites of the lymph node. So it starts like a discrete lymph node, then it can progress to matted lymph nodes. Then there will be caseation, and that leads to an abscess formation, cold abscess, because there is no signs of inflammation like tumor or dolor. And ultimately, this abscess will rupture and give rise to a discharging sinus. So this is how the tubercular lymph node progresses from discrete to the discharging sinuses. So coming to the pathogenesis, the very important part here, you just see from what I'm teaching now. So the primary infection will be there. Infection means the organism enters. So most of the time it will be pulmonary. Majority of the time it will be pulmonary. From there, the organism is picked up and it is reaching to the lymphatic route. So from there, via the lymphatic channel, these bacilli, they reach the regional lymph node. So once they reach the regional lymph node, there occurs the activation of the macrophage and T lymphocyte. So it's called as a cell-mediated immune response. Cell-mediated immune response. No audio. Just can others confirm?
You are loud and clear, doctor. You are loud and clear.
Okay, thank you. Okay, so then after the immune response occurs, there is a granuloma formation, which is very, very important for the pathogenesis of tuberculosis. Okay. And in that granuloma, what do we see? We see an epithelioid cell, we see a giant cell, that is Langhans type of giant cell, and a lot of lymphocytes. And a very classical, typical necrosis which occurs in case of tuberculosis is caseous necrosis, which happens in the central part. So these two are very important findings of the tuberculosis. Okay. And ultimately, the caseous necrosis will liquefy because it will be thick, it get liquefied, and that leads to cold abscess, and the cold abscess opens up and forms a tract that leads to sinus. So I hope this pathogenesis part is clear. So what we can see here is infection, and that bacilli is entering into the lung, that is picked up by the lymphatic through the lymphatic channel, reaching to the lymph nodes where the cell-mediated immune response takes place. The cell and the bacilli will fight. That leads to formation of a granuloma where there is an army of epithelioid cell, Langhans type of giant cell and lymphocytes. That leads to a necrosis, that is a debris, that is a dead part of the bacilli and the injured cells. And that leads to liquefaction and leading to collection and causing cold abscess and sinus formation. So please remember here. So these blue dots in the peripheral are small lymphocytes. And this is the necrosed part. And in this between interspersed are the epithelioid cell and Langhans type of giant cell. So how does this pathological state correlates with the clinical state? So in the initial correlation part, what happens is there is a firm discrete lymph node. When there is involving the capsule, which is calling capsule, that it leads to matted nodes. And when there is a caseous necrosis, this becomes soft because the necrosed part will be very soft. And ultimately, there will be a liquefaction leading to fluctuation of the cold abscess, and that opens up, rupture, and that leads to a discharging sinuses. So this is how it correlates the pathological state and the clinical state. So when you see a clinical state, the pathological state should come to your mind. Okay, there is a soft node. So most probably already the caseous necrosis has occurred. So that is what I want to convey from this pathogenesis. I don't want you to read again from the textbook, but this is very important to correlate clinically. Okay. So who are the people who gets this tubercular lymphadenitis? The more common in young adult, okay, because the immune capacity is very good, and it's having a female what you can say predominance, which is reported in most of the series. And again, common in TB endemic countries, which are developing, underdeveloped countries. Yes, very important point is this can occur in immunocompetent as well as immunocompromised. But I will tell you the difference of how TB lymph node occurs in an immunocompetent individual and an immunocompromised individual. There is a difference. Okay, I'll come across to that slide. Okay. So our common sites, again, to make you remember, cervical lymph nodes are the most commonest site. Then we have supraclavicular, axillary, inguinal, and mediastinal lymph nodes can also be involved. So any group of lymph node can be involved, but cervical lymph nodes are considered to be as the most commonest site. So what are the symptoms the patient may have when the patient is presented with the TB lymph node? So we have majority of the constitutional symptoms. Okay. So they have a swelling. Okay. Most of the patients will have a swelling, which they will not notice, and it will remain like that. Okay. They don't develop these constitutional symptoms. Sometimes they develop it very late. So among that, we have fever and weight loss, which are considered to be as the maximum incidence of these constitutional symptoms. Night sweats, loss of appetite, sometimes fatigue. Okay, so these are the other symptoms. The most common are evening rise of temperature and weight loss. Okay, and the most common presenting complaint was the slow enlarging lymph node swelling, which they will be observing every day, and suddenly after 2 months or 1 month, it will be increased in size. What about the respiratory symptoms? It is very less. Okay, so in a TB lymph node, unless and until there is a parenchymal involvement with the mediastinal lymph node, if there is a cervical lymph node or any other group of lymph node is involved, the respiratory symptoms are quite less. So don't rely on respiratory symptoms. Don't think if there are no respiratory symptoms, less likely it is TB lymph node of the neck. No. So most of the common will be constitutional symptoms. Okay. So this is what the clinical picture looks, and we'll correlate. We have already correlated it with the pathological part, and somebody has already asked about the collar stud abscess. I'll tell about in this slide. So in stage 1, so we divide this tuberculosis lymph node examination in 5 stages. So we have stage 1 to stage 5. Okay. So in stage 1, it is firm and mobile, means it is moving. Okay. So if it is firm and mobile, that means there is just the inflammation has started. Okay. So it is freely mobile and they have a well-defined margin, and less likely it will be tender. It is non-tender. Okay. Then there will be adjacent lymph node that leads to periodinitis leading to matted nodes. So in that, what happens is they become adhere to each other. That's why the mobility reduces. Okay. And this is basically because of the periodinitis. Then it can cause the fluctuation. Fluctuation, when it begins, that means the lymph node is going into softening because of the caseation. Okay. So the nodes become softer. And in case of abscess, yes, there is a liquefaction of this caseous material. And again, the fluctuation will remain there. Okay. And it is cold despite the pus formation. I already told you the inflammatory signs are rubor, dolor, calor, tumor, and functio lisa. So these are the 5 important signs. In that, the tumor, dolor, all those things won't be there in this. That's why it is called cold abscess, and also it is suggested as collar stud abscess. And once it is left untreated, it can lead to spontaneous rupture, which can cause a chronic discharge, which is healing with the fibrosis or a scar. So that leads to a sinus formation. So most of the patients we see up to until stage 3. Okay, very few patients we see in stage 4 and 5. Okay, so what are the clinical clues which are suggestive of tuberculosis? Is multiplicity, multiple nodes are involved, and they became adherent to each other, and a central caseation necrosis. Okay, so these are the 3 important points which favor towards the diagnosis of the tuberculosis. So coming to the sites of lymph node involved. So as I already told you, the most common site is a cervical lymph node. Okay. And we have the other lymph nodes which are almost having the equal incidence. And these are all taken from different studies. We have compiled different studies and we have seen what are the studies which are reporting which lymph nodes are involved. So most of them were involved is cervical nodes which are present around the neck. And we have axillary nodes which is around 4 to 13%. And similarly, we have multiple nodules, multiple nodal groups, which is around again 14 to 15%. And inguinal nodes are also reported, but they are not very common. Okay. So these are all the superficial, accessible. When you go to the deep-seated lymph nodes, there can be mediastinal, which is paratracheal or subcarinal, sometimes hilar, or abdominal, which is mesenteric, or any other group of abdominal lymph node like retroperitoneal. Okay. So these are the sites of the lymph node when we have compiled a few studies and we have correlated it with the incidence of these nodes. So this is a very important for your day-to-day practice, and you should be knowing that enlarged lymph node is not always tuberculosis. Okay. So enlarged swelling, initially we always thought of tuberculosis, but not now. We have to think of other differential diagnoses which are also quite common. Okay. So how to differentiate that depending on the examination? So in case of tubercular lymphadenitis, already I have mentioned there are multiple matted nodes with soft caseation, necrosis, and cold abscess with sinus formation. And they do have constitutional symptoms, but they respond very well to ATT. In case of lymphoma, which is one of the important differential diagnoses for enlarged lymph node, they are rubbery. So we usually typically mention Indian rubbery consistency in our MBBS postings. And these are non-matted. And these are generalized, not only one particular group of involved. And there are these symptoms. Again, these are almost equivalent to the constitutional symptoms. There will be abdominal finding like splenomegaly. Coming to the metastatic malignancy, yes, there can be a malignant cells which will move towards the cervical lymph nodes and it can present as a lymph node enlargement. Again, these are very hard lymph nodes and these are fixed. These are not mobile like the tubercular lymph node, and you have to consider the age as well as you have to look out for any history of primary malignancies like lung malignancy or a GI malignancy, which can spread to the lymph node, and it has a very rapid progression. And when you start ATT in such patients, they do not respond to it. Coming to sarcoidosis, which is very difficult to diagnose, it's a difficult disease condition where the important point on the biopsy we get is non-caseating granuloma. So caseation granuloma is typical for tuberculosis. Okay, so granuloma can be present in other than tuberculosis condition. Here also we have a hilar lymphadenopathy. Pulmonary symptoms can also be present, and they do have systemic features. So there is no particular test, single test to diagnose sarcoidosis. It has to be clinically, radiologically, and histopathologically correlated, and you have to rule out all other common causes and then come to the diagnosis of sarcoidosis. Then we have a sister of tuberculosis, that is non-tubercular mycobacteria. Again, the incidence is not very much common, and these are considered to be as a unilateral localized disease, and there is only one node involvement, unlike the tuberculosis, which has multiple node involvement. Constitutional symptoms are not very common, but they don't respond to the anti-tubercular treatment, and they need a species-specific therapy. Okay, whichever the species of non-tubercular mycobacteria is involved, according to that, therapy has to be given, and sometimes surgery can be required. Most simple form of the lymph node enlargement is reactive lymphadenitis. We do see in case of upper respiratory tract infections or any dental infections, which patient comes to you with a very acute onset of lymph node enlargement. So don't just directly go ahead with FNAC. Look for a recent infection, any URTI or any dental infection or any ear infection. So anything, if you see and there are tender nodes which is acute in onset, and you have given a course of antibiotic and the primary cause has been resolved and it has resolved with the primary treatment, then less likely it is any other etiology. It is a reactive lymphadenitis. I hope I am clear with the differential diagnosis of lymphadenopathy. There are many other like Kikuchi, Fujimoto's disease, or Epstein-Barr virus, or cytomegalovirus. I don't want to go in detail about those things, but these are the common etiologies which you have to keep in mind depending on their consistency and their presentation, so that you should not miss the other diagnosis and label it as tuberculosis just because there is a granuloma or there is a what we can say is a necrosis. Okay. So already I have told multiplicity, mating, and the caseation. These are the three important things which are required for tuberculosis. And what are the red flag signs which are going against tuberculosis are the hard fixed node, most likely in case of malignancy, Indian rubbery consistency in case of lymphoma, again generalized lymphadenopathy, if there is a splenomegaly, or there is an enlargement of the lymph node despite the appropriate therapy, you have ruled out the paradoxical worsening, or any atypical clinical course, okay, or the constitutional symptoms are out of proportion to the nodal diseases. Okay, so always remember, granulomatous inflammation does not equal to tuberculosis, because this can be present in any other conditions, also in case of sarcoidosis. So somebody has asked, what is the NTM? NTM is non-tubercular mycobacteria. Okay, non-tubercular mycobacteria. They are the sisters. They are the sisters of the tuberculosis. So tuberculosis usually reach the lymph node, because the tuberculosis will not directly get impacted in the lymph node. Tuberculosis will go into the lungs or somewhere else, and from there they are drained through the lymphatic channel, and then they are reaching the lymph node. So lymph nodes are not the primary target in TB. But in non-tubercular mycobacteria, their primary target is lymph node. So that is a difference. So for TB, it is coming from somewhere else. For non-tubercular mycobacteria, it is directly going to the lymph node. Okay. And that is why it is secondary to the TB infection. Here it is a primary. Okay. So that is the major difference of tuberculosis and non-tubercular mycobacteria. So this is a very important, what we can say, diagnostic slide. Especially it is taken from the guidelines, national guidelines. So when to suspect a case of tuberculosis? So there is a swelling of more than 1 centimeter in neck and the armpit. Okay, and the groin of more than 2 centimeter. Plus there is a redness, fluctuation, and sinus discharge. Okay, and they may or may not be associated with the constitutional symptoms, and they have a similar swelling in the past history of tuberculosis or any contact history of the TB. So these things have to be asked when you are taking in history. So there's a patient of more than 1 centimeter, and these symptoms are may or may not be plus or minus. Okay. So in all the patients, we have to do an X-ray to look for any pulmonary TB primary, or an ultrasound to look for any hidden or deep-seated lymphadenopathy. If required, you can go for a CT chest if you are suspecting there can be possibility of mediastinal or hilar nodes. Okay. So coming to that, next point is yes. The first important question is whether the node is accessible or not, whether the lymph node is accessible for you to take the sample, to take the biopsy or not. That is important. If it is there, accessible nodes like cervical, axillary, or inguinal, you have to go ahead with an FNAC or lymph node aspirate, and you have to send for a CBNAT. Okay, CBNAT or gene expert or a TrueNAT. If it comes out as a positive, yes, done. So your work is done. You have to treat it as a lymph node TB. If it comes as a negative and you are thinking it is not related to the tuberculosis, it is not going in clinical context of tuberculosis, you have to go ahead with the biopsy. And then you have to send for CBNAT, culture, line probe assay, and histopath. Histopath is very important to be sent in case of biopsy. If that confirms a tuberculosis, it is a microbiological confirmed tuberculosis. If the histopathology is showing caseation granuloma plus or minus AFB, then it is a consistent or compatible with the tuberculosis. So according to the NTP guidelines, you have to start the treatment. If the nodes are not accessible, then what to do? You have to go for an induced sputum, okay, and you have to send it for the CBNAT. If it comes as a positive and there are parenchymal lesions, treat it as a TB. If it is negative, you have to go for a taking the tissue from the deep-seated lymph nodes. So in that we have an EBUS, that is endobronchial ultrasound, transbronchial needle aspiration, where the mediastinal or hilar lymph nodes can be easily sampled with the help of a bronchoscopy, which is attached with a ultrasound at the tip. So we have esophageal ultrasound guided aspiration or a CT guided biopsy, or other image guided samplings can also be done. Again, we are sending the same tests for this tissue, and we are going to classify it as a microbiologically confirmed or histopathologically confirmed. Okay. So consistent with the TB will be caseating granuloma with the AFB. Okay. If there is a caseation without AFB, and granuloma, then it is a compatible with the TB. So that is a two difference, consistent and compatible. So I hope this table is clear, where you have to go for a screening of the chest X-ray, ultrasound abdomen, if needed CT, if the lymph node can be accessible or not accessible, FNAC is suggestive of tuberculosis or not. If it is not suggestive of tuberculosis, clinically also not correlating, go ahead with the lymph node biopsy. If it is a deep-seated, again, the sampling techniques will be different. Okay. So this is the difference of accessible and inaccessible lymph nodes. So accessible lymph nodes include, we have cervical, supraclavicular, axillary, and inguinal lymph nodes. So in these are easily palpable and examined. FNAC can be done easily. Biopsy also can be done, and excision biopsy, both the core and excision biopsy can be done with these lymph nodes. Whereas inaccessible or deep-seated lymph nodes are mediastinal, hilar, abdominal mesenteric, or retroperitoneal. In this, the very difficult is you cannot routinely do FNAC. Here we have to go for an ultrasound guided techniques or a CT guided biopsy, or sometimes we can go for a laparoscopic biopsy in order to take the sample. Okay, so accessible lymph nodes, you have to evaluate clinically, go with FNAC, send it for smear or cytology and NAT. Okay, in inaccessible, if there is a lung lesion, you have to induce the sputum, send it for CBNAT, or you can go for an imaging CT or PET CT to see multiple lymph node enlargement and image guided sampling if required. Okay. So now we compare FNAC is better or biopsy is better. Okay. So in FNAC, what we have to see is the advantages. Okay. So here it is a minimally invasive. Okay. And the turnaround time is very rapid. You can do it in an outpatient procedure. It is not very expensive and it can be used as an initial diagnostic test. Okay. So it allows the CBNAT or TrueNAT on the aspirated material. Whereas advantages of the excisional biopsy is, yes, it helps in retaining the complete lymph node architecture. Histopathological diagnosis can be possible if you are thinking of any other differential diagnosis. It has a better diagnostic yield compared to that of the FNAC. And if there is a malignancy, you can go ahead with the immunohistochemistry markers. Okay, especially for lymphoma, we need this excisional biopsy. So any other differential diagnosis, if you are suspecting other than tuberculosis, better is excisional biopsy because it has a higher diagnostic yield. There is a retained lymph node architecture, and histopathological diagnosis along with IHC marker can also be done. The limitation here, again, what are the advantages are there will be limitation here. So the tissue architecture is not retained, can miss the Reed-Sternberg cell, which are very important and classified for lymphoma. Okay, and we are going to go for lower sensitivity in some patients, and granulomatous inflammation just on FNAC is not at all specific for tuberculosis. On the other hand, we have an invasive procedure. It needs a specialist. The cost burden as well as the turnaround time is also very high, and there can be some small scar also. But if it is done endobronchial, less likely it will be there. So FNAC or a lymph node aspirate is an initial diagnostic procedure and send it for the CBNAT. Microbiological confirmation is very much required, and you have to simultaneously send for the culture. Biopsy is recommended only when the FNAC is inconclusive and the microbiological confirmation is not obtained and you are thinking of alternative diagnosis. Okay. So there are questions. Ultrasound guided FNAC, yes, we can do ultrasound guided FNAC and diagnostic. What are the diagnostic criteria for infantile PC? Infantile PC. I don't know what is infantile PC. Yeah, ultrasound finding, I'll come to that slide again. Yes, wait. Okay. So how does this histopathology looks like? Okay, so the first important point I have told, consistent and compatible. Okay, consistency is AFB positive, compatible is AFB negative. Rest all remains the same. So we have a classical picture of epithelioid cell granuloma, Langerhans type of giant cell, caseous necrosis, and AFB may or may not be seen. Okay, so we have an epithelioid cell granuloma, which is all together these epithelioid histiocytes, and we have a giant cell, which is a conglomerate of other cells, and we have a central necrosis. So when we call it as consistent, we have an AFB demonstration. We call it as a compatible where AFB is not demonstrated. Okay. So you can see this picture here. These are all epithelioid cell granuloma, and central part is the necrosed part, and small blue nucleus is lymphocytes. Okay, so histopathology is essential when FNAC is inconclusive or you are thinking of lymphoma or malignancy as a potential differential diagnosis. Granuloma alone, I am telling you again and again, is not specific for tuberculosis. There should be a presence of caseous necrosis and may or may not be positivity of microbiological confirmation. Okay. So coming to these microbiological tests, what we do, whatever sample we take, for example, the FNAC or the lymph node aspirate or the biopsy tissue or sometimes the cold abscess, the pus we drain or the induced sputum, we need to send it for AFB smear, okay, which is inexpensive, rapid. Or we can go for more sensitive CBNAT, that is cartridge-based nucleic acid amplification test, which can detect the DNA of the tuberculosis. And also it helps in detecting the resistance to the drugs. Again, it's a rapid diagnosis, okay, where there is having a high specificity. TrueNAT and CBNAT, it's almost the same, but the difference is it is a two-step procedure in TrueNAT, whereas in CBNAT, it's a single-step procedure. It also detects both MTB and rifampicin resistance. Culture is considered to be as a gold standard. Okay, if culture is positive, means it is a tuberculosis. So it's a highest microbiological confirmation, but it has a very long turnaround time, and it can be coupled with the drug sensitivity testing. So once it is positive, you send it for the sensitivity to the first line and second line drugs. So drug sensitivity susceptibility testing, we can go for molecular or phenotypic. CBNAT can detect rifampicin. Line probe assay can detect both the rifampicin and isoniazid resistance, whereas culture, that is MGIT, that is mycobacterial growth indicator tube, MGIT tube culture is also very, very important. So any sample you collect which has to go through these microbiological testing. Okay. So as already somebody has asked, what are the ultrasonographic findings? So this is an imaging slide of the lymph node. So chest X-ray, why we have to recommend in all the patient is we have to always rule out the coexisting pulmonary tuberculosis. Okay. So there can be upper lobe infiltrates or a fibrocavitatory lesion, or sometimes there can be an effusion or a miliary tuberculosis. Okay. So why this is very important? Because the presence of pulmonary involvement can change the classification of the disease, because and also the infectivity assessment. These are the two important points. So classification means if there is a pulmonary TB with a lymph node involvement, it is a PTB with extrapulmonary tuberculosis. And if there is no pulmonary TB, only lymph node involvement, it is purely a extrapulmonary tuberculosis. That remains to classification. Infectivity assessment, if there is only lymph node and there is no parenchymal involvement, sputum also came negative, the patient is less infective or almost non-infective because there is no parenchymal lesion. Okay, only isolated lymph node will not be an infective patient. If there is a pulmonary lesion with a lymph node, then the patient can be infective. So infectivity assessment is also very, very important. So that's why we do chest X-ray. Ultrasonography, it's a very important, it is non-exposure to the radiation. We can do it in accessible nodes like cervical, axillary, or abdominal deep-seated nodes also can be seen. So we have a hypoechoic nodes with the what we can say matting, and there is a central necrosis and fatty hilum is lost. So you can see a hypoechoic means it appears more dark, okay, with the loss of fatty hilum and a central necrosed area. And contrast CT is very important. Don't go with the plain HRCT. If you want to check the lymph nodes, mediastinal lymph nodes, or any pulmonary lymph nodes, please don't order for a high resolution CT plain. You always have to order a contrast enhanced CT, CECT, which is very important to visualize mediastinal structure like mediastinal lymphadenopathy or any deep-seated lymph nodes of abdomen. Okay. So in that findings are peripheral rim enhancement will be there. You can see these peripheral rim enhancement, and there is a central low attenuation. Okay. And there will be conglomerate. There will be this joining of multiple lymph nodes. And sometimes if the lymph nodes are too big, they can compress the esophagus, they can compress the trachea, they can compress the vascular structure. So that will happen when there is a very bigger lymph node. So sampling techniques are EBUS and EUS, that is endobronchial ultrasound, esophageal ultrasound. With the help of this, we can sample the mediastinal nodes, hilar nodes. So it helps you to avoid a surgical mediastinoscopy. Okay. And PET-CT is not regularly ordered in this patient. Ordered only when there is a persistent lymphadenopathy and you have to exclude the lymphoma. Okay. But there are limitations with the PET-CT because PET-CT has a glucose and it is taken up by almost all the rapidly proliferating cells. So it rarely differentiates between TB and malignancy. Okay, so this is how the imaging workup seen in case of lymph node tuberculosis. So after all that assessment and diagnosis, let us go to the treatment part. In the treatment part, what we see is the standard treatment regimen is followed in case of TB lymph node also. So we have 4 important drugs like isoniazid, rifampicin, pyrazinamide, and ethambutol, which can be given for an intensive phase of 2 months and followed by a continuation phase of 4 months, where again we divide into H, R, and E. So HRZD and HRE are the standard treatment protocol, and it should be given minimum to the duration of 6 months. And during this treatment, what you have to monitor? Whenever patient comes back to you, you have to check the lymph node size. Not necessary that the lymph node size has to reduce every time. There should be resolution of fever and constitutional symptoms. This is very important. The patient should feel better clinically. The reduction in the lymph node size may or may not occur, but the resolution of these constitutional symptoms are must. Patient should have weight gain or there should not be any weight loss. Okay. And what we are going to see here is healing of sinus tract should be there. Healing of sinus tract should be there. Okay. So persistent lymph node, what we are going to see here is the persistent lymph node after the treatment. What I have told is same thing. The reduction in the lymph node size is not required mandatory. The symptoms should improve, weight should improve, and if there is a sinus tract, that should heal by fibrosis because you are treating the infection. So why does the lymph node size may not increase? Sometimes there will be small residual lymph node despite the particular cure. Okay. And what we can see here is residual fibrosis or caseous necrosis may remain inside the lymph node, or the persistent palpable lymph node alone, I'm telling alone. If there is other symptom and other things are there, then you have to think of treatment failure. But only there is a persistent palpable lymph node, rest all things are fine. Don't consider it as a treatment failure. Okay. So duration, as I already mentioned, it has to be given 6 months. Sometimes they extend it up to 9 months. So majority of the case series, what they have showed in TB lymph node, they extend up to 7, 8, or 9 months. So when you need to reevaluate, the nodes are enlarging during or after the treatment, or any new lymph node appear and the constitutional symptoms persist and there is no clinical improvement, all together should be there. All together should be there. It should not be like only one thing is there, all together should be there. Then only you have to reevaluate with the help of excision biopsy, send it for histopathology, repeat the CBNAT to rule out resistance, and confirm with the gold standard diagnosis of mycobacterial culture, and also send it to the drug susceptibility testing to see whether the drugs which are given by you are sensitive or not. Okay. So this is how you have to treat and monitor the patient of TB lymph node. So this is how you assess the response for 3 to 4 months. Again, this flowchart is taken from the guidelines. So what we can see here is if there is a response to the therapy, it is a favorable therapy where there is a decrease in size of the lymph node and also the systemic symptoms are reduced and there is a continued treatment. Okay. But there is no response to the therapy. Okay. That means it is unfavorable. So there is an increase in size of the lymph node or there are signs of inflammation. Okay. So you have to check the previous culture report. If the culture is not performed, send it to the culture. And once the culture shows drug susceptibility tuberculosis, then there is a paradoxical worsening. When you call it as paradoxical worsening, when the size increases, lymph node appears, new lymph node appears, so new inflammation develop, and there is no other clinical symptoms. Okay. So then you have to refer to higher center and you have to continue the treatment. Whereas therapeutic drug monitoring has to be done. And what you have to do here is it requires a suboptimal, what we can say here is consider when response remains suboptimal despite the drug susceptible tuberculosis. Okay. And then what we can see is culture shows drug resistant tuberculosis. Then you have to treat it as a MDR TB. Okay. And if the constitutional symptoms persist and the other alternative diagnosis, what I have told, sarcoidosis, lymphoma, and all those things has to be ruled out. There is one more entity called BCG lymphadenitis. There is one more entity called BCG lymphadenitis. Okay. So in that, what we can see is the usually occurs within 2 years of the BCG vaccination, and the site are usually axillary or supraclavicular nodes are involved here. Systemic symptoms are usually absent. So what investigation you have to do is FNAC, which is suggestive of granulomatous inflammation, but there is no acid-fast bacilli. Okay. You wait and watch with a what we can say either no treatment or short course of isoniazid. And what we can see here is the malignant transformation cannot be differentiated from the BCG lymphadenitis. So BCG lymphadenitis is not very common. Okay. So how do you assess the paradoxical reaction? How to treat this paradoxical reaction? How to identify this paradoxical reaction and how to differentiate it from the treatment failure? So coming to the definition part, okay, there are a few more questions. I'll tell you. Okay, highly informative treatment of latent TB. Okay, I'll tell later at the end of the slide. LFT, uric acid, ophthal symptoms during treatment. Yes, it is depending on the drug. Okay, if you are suspecting any side effect, that is different. I am discussing about the paradoxical reaction and treatment failure. Please explain MT test, Manto test. Okay, so Manto test. Okay, it is a skin test. It's an intradermal test where we inject an antigen, and after 72 hours, we are assessing the induration, and that has a lot of false positive. So we don't use it now. Okay, so that is not an important aspect now. So previous slide you wanted to see. Okay. Okay, so coming to the next slide, how do you call it as a paradoxical reaction? It's a clinical or radiological worsening of a pre-existing lesion or appearance of a new lesion after the effective ATT has started, despite the susceptibility and the adherence to the treatment. These are the two important words. So susceptibility is there and treatment is adhere. Okay, these two are cleared despite that there is a worsening. So within first 3 months, it can occur. And why does it occur? Is because not due to treatment failure or drug resistance, it is because of the exaggerated host response. So your host immune response is becoming very exaggerated when you compare it with the this thing, what you call it as this thing. So when we come to the patient start antitubercular therapy and lymph node enlarges or new node appear, then there is a paradoxical reaction, and treatment failure means ongoing active disease due to treatment ineffectiveness. So again, same thing with the enlargement of lymph node, there is a systemic symptoms are present, then only we are going to call it as a paradoxical reaction. Okay. So usually that happens within 3 months and it can happen anytime and symptoms may worsen here. Okay. So how to manage this paradoxical reaction? Continue the antitubercular treatment, reassure the patient that there is nothing wrong. You are going to get all right. And if there is an abscess, you can aspirate it. And sometimes you can give anti-inflammatory therapy. Only if the patient worsens clinically, then you have to reevaluate the patients. So coming to the complication, what complications can happen in TB lymphadenitis? So cold abscess is, yes, one of the, what you can call it as noted complication, where there is liquefaction of the caseous material, fluctuation can be present and painless swelling can be there. Okay, minimal erythema or warmth and characteristic local complications. What you have to do in this is you have to aspirate, and repeated aspiration can be required in this cold abscess. Not more than that, continue antitubercular treatment. Sinus tract formation, yes, there can be a spontaneous rupture. It can lead to persistent discharge or delayed healing or secondary infection. So again, same thing. You have to continue ATT and with the local wound care or a secondary infection if present. Fibrosis can occur because any tuberculosis anywhere in the body heal by fibrosis and scarring. So it heals by fibrosis leading to nodular thickening, or sometimes they can cause a cosmetic deformity. So usually no intervention is required for the fibrosis or scarring. Compression effect can be seen in the deep-seated lymph nodes where there can be airway compression or bronchial narrowing or dysphagia. So again, management is ATT. Only when the symptoms are not improving, you can go for a tissue diagnosis. Okay. And if there is a severe compression can occur, then you have to go for a intervention or a surgical management of that compression. Secondary bacterial infection do occur in case of tuberculosis that can lead to pain, tender, okay, or erythema. So appropriate antibiotics and drainage of the abscess and might send for a routine culture. There can be chances that the patient may have residual lymphadenopathy or calcification inside the deep-seated lymph node. So persistent lymph node or calcified nodes are the signs of healed lymph nodes. So you need to follow up them. Okay, if it is a superficial and it's a very large node cosmetically causing problem, you can go for an excision and send it for a histopath and culture. Okay, and if there are constitutional symptoms, again they recur, then you have to go for an excisional biopsy. So that time you have to wait and watch. Only if there is a cosmetic problem or the these things have been come, then only you have to drain. Okay. So what is the role of surgery in TB lymphadenitis? What is the role of surgery in TB lymphadenitis? So first thing is diagnostic procedure. Yes, excision biopsy, we need surgery only when the FNAC is inconclusive. Microbiological tests are negative. and there is a diagnostic uncertainty or you're suspecting of any malignancies like lymphoma or malignancy. Therapeutic procedures, yes, needle aspiration can be done for a cold abscess or a fluctuant lymph node or a symptomatic swelling, or a drainage of the secondary bacterial abscess. When there is a painful abscess, tenderness is present, that means there is a secondary bacterial infection. Selected surgical excision when there is a residual node which is very large or a recurrent sinus formation, or an alternative diagnosis is suspected, then you have to go for an excision of the biopsy. So ATT remains the cornerstone of the treatment. Most of the patient, they do not require surgery. Sometimes these residual node can be wait and watch and observe if clinically stable. Only when there is an enlarging node or a recurrence of the constitutional symptoms, you have to go for a reassessment. So coming to a very important slide of today's webinar, tubercular and non-tubercular lymphadenitis. So the age group which is seen in tubercular is adolescent, and here it is in children. Immune status, it can occur in any patient. Here it is in immunocompetent individual. So these are the group of lymph nodes involved here. Here the submandibular and the preauricular lymph nodes are involved. Again, there are multiple or matted nodes are there. Here it is localized or unilateral node. Constitutional symptoms are common in tubercular, but they are uncommon in non-tubercular, and pulmonary TB association may coexist. Here it is very, very rare. AFB smear is positive in both. Please remember this 2 points. CBNAT is positive in this case, but it is usually negative. So whenever the AFB is positive and CBNAT negative, if there is a clinical context of non-tubercular mycobacteria, think of NTM. Okay, so culture has to be sent, which is very important to gold standard to diagnose. And similarly, on histopathology, we have caseating granuloma and response to ATT. Yes, it is very, very good. And here it is poor. Okay. And here the preferred treatment is ATT. Don't go for surgical unless and until there is a complication. Antitubercular treatment is enough to cure TB lymphadenitis. Here they might need a surgical excision to confirm. So diagnostic clue is CBNAT positive and response to ATT. Here AFB positive, CBNAT negative and not responding to the ATT is a clue for non-tubercular lymphadenitis. And how does this tubercular lymphadenitis presents in an HIV positive compared to that an HIV negative individual? So they have a multifocal lymphadenopathy where there is multiple nodal groups are involved. Only one cervical lymph node is less commonly involved in case of patients who are having TB with HIV. And pulmonary TB is also more commonly associated with the pleural or pericardial involvement, and sometimes there will be dissemination. Okay, so histopathology, they have a classical caseating granuloma will be seen very less frequent because the immunity is not there. So the necrosis less likely it happens, but there will be suppurative pattern and a non-reactive histology can be seen. Okay, so the difference between these is multifocal lymphadenopathy. Here it is usually localized. Multiple group of lymph node. Okay, the difference is multiple nodes is different. Multiple group of lymph node is different. Multiple group of lymph node means cervical, axillary, mediastinal are involved. Multiple group means multiple nodes means in the cervical only there are multiple nodes are involved. So that is the difference between multiple group and multiple nodes. Disseminated disease is common in HIV positive when compared to that of HIV negative. And the differential diagnosis here, it becomes very broad and it depends on the underlying CD4 count. Here the differential diagnosis is not very broad. So do you remember our case? We had a case of bilateral axillary swelling. It was chronic, 9-month, left was bigger than right. We did an FNAC and we got a granulomatous lymphadenitis. Then I asked you what you want to do. Some people have told CBNAT, some people have told excision biopsy. We did CBNAT in that patient, CBNAT came negative. Then we went ahead with an excision biopsy. Okay, so you can see clearly there is a contrast CT which showed the lymph nodes. Okay, the mediastinal axillary lymph nodes are here, and the patient did not have any pulmonary or a parenchymal lesion. Okay, patient did not have any pulmonary or a parenchymal lesion, and it was not fitting completely into tuberculosis. There was no caseous necrosis on FNAC. Only granulomatous lymphadenitis was present. Okay, so we were like, okay, this will not correlate with the tuberculosis. So we went ahead with a lymph node biopsy and we sent it for histopathological examination, and this was the finding in the histopathological examination. Can anybody tell what is the histopathological finding here? What do you call this cell as? Okay, this is an entire cell here. So this was a demonstration of Reed-Sternberg cell. Okay, and there was no microbiological confirmation of tuberculosis. So Reed-Sternberg cell, they have a whole eye appearance. Okay, whole eye appearance is there of this Reed-Sternberg cell. I think you guys have read for your entrance exam. Okay, so the final diagnosis we got was classical Hodgkin's lymphoma. So imagine if this patient had FNAC granulomatous lymphadenitis, we had started him on ATT directly, we would have missed the diagnosis. Okay, and since this patient does not have any pulmonary or a pleural lesion, okay, he had only axillary lymph node without any mediastinal or a hilar lymph node. Okay, because mediastinal and hilar lymph nodes are very commonly involved in lymphoma. He did not have any involvement of the mediastinal or hilar node. He only had axillary, bilateral axillary lymph node, which was left more than right, which was very chronic in nature, 9 months. And FNAC showed granulomatous lymphadenitis. Okay. And we went ahead with the biopsy, which showed a Reed-Sternberg cell, which is a classic Hodgkin's lymphoma. So isolated axillary lymph node involvement in lymphoma is also very, very rare. So don't think that it is just a TB because it is only involving axillary lymph node. There is no involvement of mediastinal. So I have reported this case. So if you want to learn about this case report, you can go and search this silent swelling and loud diagnosis. So it is reported in International Journal of Medical and Pharmaceutical Research. I have already published it. Okay, so you can go to this case report and study about this. Okay. So what our case teaches us is not every granuloma is a tuberculosis. Granulomatous inflammation is a pattern. It is not a diagnosis. Constitutional symptoms are also not very specific for TB. They can also occur in lymphoma. They are called as B symptoms. Microbiological confirmation is very, very important because microbiological evidence is very, very important nowadays for TB because we have a provision of doing CBNAT. We have a provision of doing TrueNAT. They are all very accessible. So get microbiological evidence and they have more sensitive and specificity when you compare to the AFB smear. Excisional biopsy, very much gold standard when the doubt persists. Okay. And you have a confusion with an FNAC, go ahead with an excisional biopsy before labeling him as a TB and starting with the treatment. Always reconsider diagnosis when the clinical picture does not fit. Okay. So always think, okay, if it is not TB, don't blindly start with the tuberculosis. Lymphoma is a very important mimicker of TB lymph node. So this has to be kept in mind when there is an young age group or very old age group and isolated lymphadenopathies are there and it is not favoring towards the tuberculosis. So let's solve some questions. Are you all ready to solve this question? A patient with tuberculosis cervical lymphadenopathy developed enlargement of the lymph node after 6 weeks of starting ATT. So fever has resolved, but the lymph node size weight has increased, but the lymph node side enlarging. So what to do in this case? What is the most likely explanation? So very good. So you are correct. So it is more likely a paradoxical reaction because the clinical symptoms are subsiding and the lymph node are persisting and it may persist. Okay, sometimes there can be a residual lymph node. So a patient who had a persistent lymphadenopathy even after completion, but no constitutional symptoms and nodes remain stable. So what do you want to do? Yes, again it is C. So he has completely cured. Okay, you don't have to extend again. You have to observe with the follow-up. If there is recurrence, again you have to do an excision biopsy and confirm the diagnosis. So AFB smear from a lymph node aspirate is positive, but CBNAT is reportedly negative, and patient does not show any good response to ATT. Yes, so this is a classical non-tubercular lymphadenitis where the patient aspirate is positive for AFB, CBNAT is negative, and he does not show any response to ATT. So in case of TB lymphadenitis, which group is commonly involved? It's a cervical. Okay. So characteristic histopathological finding in tubercular lymphadenitis is caseating epithelioid granuloma with Langerhans type of giant cell. Very good. The physical finding most suggestive of TB lymphadenitis. Second, matted lymph nodes. Good. So according to the guidelines, the preferred initial microbiological test on a lymph node aspirate. What is the first preferred microbiological test on a lymph node? Okay, we have to go for a CBNAT or an expert because the sensitivity and specificity is quite high. Okay, so the first slide. So let us see the answers. Okay, so what we can see here, first I asked you, granulomatous lymphadenitis on FNAC confirms tuberculosis? No. It can be seen in multiple causes, so microbiological confirmation should be attempted. Mediastinal TB is classified as pulmonary TB? No. If there is no pulmonary involvement, then it is less likely classified as a pulmonary. It is classified as an EPTB. Enlarging node during ATT always indicate treatment failure? No. It can cause enlargement and new nodes during effective ATT and not a treatment failure unless and until there are systemic symptoms worsening or any new systemic symptom has developed. A negative CBNAT or gene expert rule out lymph node TB. It has a limited sensitivity in extrapulmonary TB. So a negative result does not rule out excluding TB. You will have to go for a histopathological examination, caseation, necrosis. So it can be a compatible, not consistent. If it is positive, consistent TB. If it is not positive and other features are there, it is a compatible. Excisional biopsy may still be necessary despite FNAC suggestive of TB. Yes, it is indicated only when the diagnosis remains uncertain or alternative diagnosis like lymphoma is suspected. So I hope these myths are cleared into the fact. Okay. So thank you. The eye sees only what the mind knows. So if you have the differential diagnosis of the lymphadenopathy and you have a different approach of asking these symptoms, then only you will be able to see. So when your mind knows, then only you will be able to see the other causes other than tuberculosis. Okay. So now let us answer the questions which have been pending there. Okay. So let us see. Okay, so we have one big question was there. Let us see that. Good evening. One patient came to OPD, 23-year-old. She was diagnosed with cervical lymphadenopathy by FNAC 2 years back, taken 6 months AKT, got well. Then just after 6 months, got again evening rise of temperature, decreased appetite, mild pain loss, slight exhalation, enlarged, movable, on and off pain, persistence 1 year, no tiny pulmonary symptom. Advise FNAC. No, you can go ahead with the biopsy now. Okay, you can go ahead with an excisional biopsy. You will only come to know. Okay, because repeatedly they are having symptoms and she is improving. That means it is TB. But the thing is, again, she had a recurrence of symptoms, and just confirm whether they have taken appropriate dose, whether they have taken all 6 months. Okay, and whether they have not skipped the dose. And it should be according to the weight band. It should be according to the weight band. If FNAC comes negative, you don't do FNAC now. You directly go ahead with the biopsy. Okay, and check for ultrasound abdomen and pelvis if there is any other lymph nodes are there. Okay, any other group of lymph nodes are involved. If it's an accessible lymph node, go ahead with the biopsy.
Thank you, doctor. A small announcement. We have pasted the certification registration form in the chat box. Please do fill the chat form to get your certificates.
Surgical procedure for TB lymphadenopathy once again. Okay. So surgical procedures. Yeah. Okay. So this is about the surgery. So only it is done when there is a alternative diagnosis or you are to going to drain the abscess or if there is any secondary bacterial infection, or you need a diagnosis. Excision biopsy, core biopsy, or anything can be done with the help of surgery. I hope you guys have got a clear idea about the lymph node TB, because we do see this in a day-to-day practice and we are still confused. What happens when it comes negative, when it comes inconclusive, and symptoms are not improving. So don't just keep TB in mind whenever you see a lymph node. Yes, commonly it is TB, but when they don't respond or when you have any slight doubt, then think of any other differential diagnosis, ask for other investigations, evaluate, go with the biopsy.
Dr. Twinkle says, really good session. Enjoy learning with session. Thank you so much.
Thank you, Dr. Twinkle. Thank you, Dr. Ravina. Then thank you everybody for your appreciation.
Yeah, Dr. Twinkle, you can unmute yourself now.
Good evening, sir.
Yeah, tell me.
Sir, recently I just shared one case. Just 2-3 days ago, I have one patient which already diagnosed with the Hodgkin's lymphoma, taking a treatment from the Tata Hospital, Bombay. Initially, she took a treatment 2 months like nivolumab and all the diseases in under control. After that, she diagnosed with little breathlessness and exertion. We done a CECT chest. There is a big mediastinal mass. They're compressing the terminal bronchus. So we go for the endobronchial video bronchoscopy with endobronchial mass tissue core biopsy. Still, my biopsy report is pending. So I just want to know whether there is a recurrence of Hodgkin's lymphoma, yeah, whether there is a newly infective disease condition like a tuberculosis.
No, you have to correlate other things also. Like what happens is initially CT had any mediastinal lesion or not, and whether the lesion was there before or it is a newly diagnosed lesion. Because what happens is usually lymphomas, they have mediastinal lesion before. Okay. And if the treatment is not given to the proper time, yes, there can be recurrence. And also you have to rule out tuberculosis because it's a cancer patient. So chances of tuberculosis is also very high. So you send both AFB, CBNAT and histopathology. Okay. Everything you have to send for the sample. Sometimes it can be both. So it's like a tricky situation now. So you need to be diagnosing in all the aspects, because the cancer patient, it's one of the immunocompromised state. So tuberculosis is also quite common, and it can be recurrence of lymphoma also. What's the age of the patient? Okay, Hamza is asking, isn't the treatment regimen updated? Hamza, I want to 37-year-old. Okay, more chances of lymphoma. We have to think young age. It's a bimodal incidence. Okay, so Hamza, which treatment regimen you are talking about?
Dr. Ramza, if you want, you can
Yeah,
unmute
you can
yourself.
unmute or you can type also. That's not a problem.
Yeah, you can unmute yourself if you want to talk to directly to the doctor.
Hello.
Yeah. Yes, Hamza, tell.
Yeah,
Yeah, good
good
evening.
evening, Dr. Sohail.
Yes,
Sir,
yes.
I wanted to know that, we have been reading this that the TB treatment guidelines have been updated in
Yeah, that's
September
what I want
27.
to ask, which treatment regimen you have heard of?
No, sir, we had been seeing that ethambutol has been taken out and moxifloxacin has been added. So, no, only this thing I wanted to
No,
make sure that whether
I
it
think
is
you're talking
being.
about that 4-month regimen where moxifloxacin has been added I think instead of pyrazinamide, not ethambutol, I guess. So that is again a WHO guideline. NTEP guideline you have to see for India. Okay, you have to see National Tuberculosis Elimination Program. TBC India is a website, so that you have to follow. It is not yet accepted by NTEP. It is given by WHO. CDC, that is a CDC. So they have given 4 months. But what I feel, my opinion, I'm telling you, in an endemic country where the burden of TB is quite high, again, the 6 months treatment, okay, to reduce it to 4 months is little, what we can say, harmful more than benefit. Okay, it is good when there is burden is less. Okay, just to reduce the pill
Thank you, sir.
burden,
Thank you.
they might reduce the duration. Okay. Otherwise, 6 months the patient is tolerating, and that is going on since very long time. We have come to 6 months. Now we are coming MDR TB also, we are reducing the duration. Okay, so that's all under work. So, but still for drug sensitive TB, we are using 2 months HRZD, 4 months of HRE. Okay.
Fine, sir.
Yeah.
Thanks for answering.
No problem. Do we use streptomycin presently? Less likely. Streptomycin is not used now very commonly. Only 4 drugs are there, HRZD and HRE. Yes, streptomycin has a role when you are suspecting ATT-induced hepatitis, where patient is not tolerating isoniazid, rifampicin, pyrazinamide. Then we don't have any option. We have to introduce streptomycin. We have to introduce levoflox. We have to go with the ethambutol. So that time, in selected conditions, we can use streptomycin, but not routinely when the patient is tolerating all other drugs like HRZD.
पीरियड कब आए?
हेलो सर.
Yeah.
लास्ट पीरियड कब आए?
पिछले महीने 20 तारीख.
Hello.
Hello.
Hello, sir. Can you please tell me the treatment of miliary tuberculosis?
It's same. It's
Same.
any tuberculosis is same except drug resistant or drug sensitive. The duration changes. In miliary TB with CNS involvement or a skeletal involvement, you have to go for a year duration. Otherwise, 6 months. Only thing is you have to see whether it is sensitive or resistant. Then only the treatment changes. Any TB treatment remains the same. It is drug sensitive. If it is drug resistant,
Yes, sir.
change.
Thank you, sir.
Okay, no problem.
Thank you, doctor. Thank you so much.
Thank you.
I will. We have one more question, Dr. Do we use?
I've already answered.
Perfect. Perfect.
Yeah.
Perfect. So I am dropping the certificate link again. If someone has missed it, please do click on the link and submit the form. Just to tell you further, please fill the form properly so that the certificate will be sent to you directly the moment you click on submit button. Sometimes it will land on spam folder. Please check in both inbox and spam folders. Thank you so much. How to manage primary complex?
Primary complex is a pathological this thing entity. Don't compare it with the clinical entity. Treat clinical patients. Don't treat pathological. Okay. It's a primary complex, Gons focus. They are all pathological words. So that we usually don't label as a clinical diagnosis. We have to treat either infection or not. That's an important thing. There's a disease or no disease that we have to see.
Perfect. Thank you, doctor. Thank you so much.
Thank you. Thank you, Vijay. Thank you
For
wonderful session. Thank you for everybody for patient listening. Thank you, Mediversal, for organizing this webinar and giving me an opportunity. Thank you, Vijay.
Thank you, doctor. Thank you so much. Thank you, doctors, for joining. To all the doctors, I would extend a great thanks for joining the session. And as you know, we are conducting a lot of session. Please do stay active in the groups to get the webinar links. If any of your fellow doctors want to join, please you can directly join them or reach out to us to make them a member of the groups. Thank you so much. Thank you for all. Thank you. Good night.